Good afternoon, everybody. I'm Dr. James Larson. I am a general internist with fellowship training in geriatric medicine. I practice primary care for people age 55 and over at Loma, and I've been doing that for the last 23 years. The average age of the patients in my practice is around 80. And I had about 4 or 5 patients turn 100 this last year, which was, I don't think I had very much to do with that, but it was a lot of fun to watch. So, I was asked to give a talk about, I'm also the medical director of our bone density scanner at Loma, so I was asked to come and give a talk about osteoporosis and bone density screening. So I'll just start out by saying a few words about osteoporosis, and then I'll talk a little bit about bone density testing and what we recommend for screening for that. And then we'll have some time for some questions at the end. I have a little bit of an informal presentation today. I thought we'd just come and have a conversation about osteoporosis, but I did bring a few little show and tell things for you too. Osteoporosis is actually one of the more prevalent diseases in the world and a major healthcare issue in the public health issue in the United States. Every year, there are approximately 1.5 million osteoporosis-related fractures that occur in the United States alone. And the total healthcare cost of those fractures runs up into the somewhere in the range of $13 to $17 billion. And it isn't just the monetary cost of that we have. There's indirect costs too, and there's also human suffering costs to that. Hip fractures are still one of the more common reasons why people move into assisted living facilities or what we used to call nursing homes. There's still over 10,000 people who die every year of complications of hip fractures and other fractures. In addition to hip fractures, there are compression fractures of the spine, and those are actually the most common types of fractures, but they often go undiagnosed because people just think they have a severe back pain. They don't get an x-ray taken, or the doctor just thinks it's low back pain and doesn't take an x-ray, and it takes anywhere from 6 to 8 weeks to get better, and then they just go around with a compression fracture that they don't know about. Other people that get compression fracture of the spine end up with long-term pain and disability as a result of that. But there's about twice as many spine fractures as there are hip fractures per year. Wrist fractures are also a problem. One definition of osteoporosis is that if you suffer a fragility fracture that's caused by a standing fall, so if you fall down and break a bone, then you have osteoporosis no matter what your bone density is when we do a bone density scan on you. If there's an overwhelming trauma, such as a motor vehicle accident or a fall from a height, like from a ladder or something like that, then that doesn't fit the definition of an osteoporotic or a fragility fracture, although it doesn't rule out the possibility that you may have osteoporosis. Osteoporosis is much more common in women, and there are several reasons for that. One is that women live longer, and so they have more time to develop it on average. But there are 2 major factors involved in developing the condition of osteoporosis. One is how high is your peak bone mass that you achieve in a lifetime? And then the second thing is how fast you lose the bone mass. And on average, men achieve a higher peak bone mass by a little bit, not a lot, but a little bit. And then there's a phenomenon that occurs in women after menopause where there is an increased velocity of bone loss that starts to occur, and it occurs over about a 10-year period, where you lose bone at a faster rate than you do at other times in your life. Men lose bone every year, but they do it at the slower rate that is the baseline over a lifetime. So those are the two reasons why it's more prevalent in women than men. Men do get osteoporosis too. They just usually get it about 10 years later than women, unless there are specific risk factors involved. Some of the things that you can do to, what are some of the things that you can do to achieve a higher peak bone mass? Does anybody have any ideas of some of the things that you can do? And what time of life do you think that we achieve peak bone mass? Does anyone have any ideas about that? It actually is earlier than that. Your peak bone mass pretty much occurs at the time that you complete puberty. So there's a tremendous increase in the mass of your bone in women in probably starting in the preteen years now, and then during puberty. And so you reach peak bone mass by the time you're around 20, or maybe in your early 20s. Most of the day, unfortunately, a lot of people don't get enough calcium in their diet, especially teenagers, and unless they happen to drink a lot of milk, and then there may be some risk to drinking a lot of milk too. So, and I'm the father of two adult daughters now, and during the time that they were in that period of their life, the last thing in the world they wanted to hear was their dad talking to them about how they should take some extra calcium because they might develop osteoporosis when they're 70 years old. They're not really thinking about that type of thing. So, what else? Smoking is a big factor. Smoking is a huge risk factor, and again, we're starting to see an increase in smoking in young people these days, but smoking does accelerate the loss of calcium from bones. Caffeine may be a factor. I'm not sure how much it is. It's not as much as some of the other things. The other one that seems to be the really big factor that has come to our attention is vitamin D. And nowadays with the advent of computers and computer games and things like that, a lot of people don't get outside very much. Vitamin D is produced by exposure to the sun. Of course, the downside of that is if you spend a lot of time in the sun, you start running a risk of skin cancer too. So there's no free ride in this life. So, but yeah, possibly. So the recommendation is to get at least 800 international units of vitamin D a day. So, and again, teenagers and preteen girls are not really thinking about what they should do to get extra vitamin D. Usually that's not real high on their list of priorities. So now that my daughters are adults, they're starting to think more about their long-term health, and they're asking these questions. And unfortunately, the time when they really needed that information and needed to be internalizing it was, about 5 or 6 years ago or more, so 10 years ago. So the things that can build peak bone density are weight-bearing exercise, adequate calcium in the diet, adequate vitamin D, and avoidance of smoking. So, okay. So those are the big ones. There are high-risk medications. Hopefully our young people as a whole on average are not being exposed to those, but there are young people that have chronic diseases that may require some of those high-risk medications, and we'll talk a little bit more about those in just a minute. Some of the things that then, what are some of the things then that increase or accelerate bone loss? Well, a lot of them are the same things, or the lack of some of the same things that we talked about that help to build bone in the first place. So Vitamin D deficiency is a common cause of accelerated bone loss. Smoking is a cause of accelerated bone loss. Lack of adequate calcium in the diet. And high-risk medications. So what are some of the high-risk medications that we should be aware of? One that's really causes severe osteoporosis is one called prednisone or corticosteroids in general. And those are medications that can be very useful in people that have chronic inflammatory diseases, such as maybe, lupus or inflammatory bowel disease or asthma. Any type of inflammatory disease is something that will respond to corticosteroids. But the downside to corticosteroids is that they accelerate bone loss. Sorry about that. But they accelerate bone loss. Fortunately, there is a way to protect against the bone loss that's related to glucocorticoid use, and that is taking certain medications, bisphosphonates. And there are good studies that show that if you take those medications as a preventative measure when you're on the corticosteroids, that you can help to prevent the bone loss that occurs with that.
What if you just take the steroids like once a year? Like when I get asthmatic bronchitis, the doctor prescribes it for like a week. And it's like once a year.
A 1 week course of corticosteroid once a year is probably going to have a minimal, if any, impact on your long-term bone health. Again, osteoporosis is a disease that comes on very slowly, and it gets better slowly too. That's one thing that I always emphasize to patients. So, yes. So, and we'll talk about that before we're done too. What are some of the other there are some other medications, though, that you should be aware of, too. One really common one, and it's available over the counter, and I'd be willing to bet that there are people in the room here who are taking them, and that is acid blockers. Things like omeprazole, Zantac, Nexium, the purple pill, all those things that block acid production in the stomach. One of the things that's required for the absorption of calcium is an acid environment in the stomach, and if you block that, then you don't get as good of absorption of calcium. So there is some evidence that long-term use of acid-blocking medications increase your risk of bone fractures and osteoporosis. So, another one is anticonvulsant therapy. So people that have seizure disorders and have to take anti-seizure medications are people who should be screened probably at an earlier age than the standard screening recommendations. Those are the main ones that I can think of. So.
What about breast cancer, like tamoxifen, some of those?
That's another one, yeah. Hormone blockers. Obviously, hormones are important for the building of bone, and loss of estrogen after menopause is also something that is a cause of osteoporosis. So if we block those hormones to treat something like breast cancer, that is a risk factor, and that is another reason for screening, for early screening. So, good point. It probably is, yeah, it probably is affected. And whether you can overcome that by taking extra higher doses of supplemental calcium and vitamin D, I'm not sure. So that's unclear. I don't know how well that's been studied. It is still somewhat controversial how much of an impact the acid blockers have on calcium absorption and osteoporosis, but there is an indication that people who take those for a long period of time are at higher risk. So,
What about phosphate, since it does affect
we'll talk about treatments before we're done, but yeah, that I will address that question before we're all done here. So.
I have osteopenia, and I'm wondering, 2.0. What are the chances that I become a
So osteopenia, the question is osteopenia. What is osteopenia, and is that a risk factor for osteoporosis? Osteopenia is an in-between state. There's and these things are based on averages. So basically, people have bone density that is on a bell curve, and you can measure standard deviations on one side or the other. And if your bone density falls outside of the middle of that bell curve, there's a range called osteopenia where you don't have normal bone density, but it's not severe enough for it to cause fragility fractures. And then there's osteoporosis, which is a low bone density that's severe enough to cause fractures. Obviously, people with osteopenia are at higher risk for eventually developing osteoporosis than someone who has normal bone density now. So osteopenia could be considered a precursor or a kind of a way station on the way to osteoporosis. It definitely is a risk factor. So what can we do to help protect ourselves against osteoporosis and be aware that maybe we have it and aware that we're at risk? And then what steps can we take to actually treat it and reverse it if, in fact, we have it? So we have the best way, there's several ways of measuring bone density, but the one that is the most widely used now is something called dual X-ray absorptiometry, or DEXA for short, okay? So from now on, we'll just use the term DEXA scanning so that we don't have to use those other big words. But DEXA scanning is a lot like just getting a simple chest X-ray, except you lie on a table and they go boom, boom, like that, and it takes maybe about 10 to 15 minutes. And it measures the density of your lumbar spine, and it measures the density of, we usually try to do the non-dominant hip. Sometimes you're not able to for whatever reason, and then we'll do the other hip. And if you can't do both the lumbar spine and the hip, then we also recommend doing the forearm also. Again, like I explained, people have a normal, it's based on a normal bone density for a 30-year-old woman is basically what it's based on. And it's based on a bell curve around that and standard deviations away from it. So if you are more than one standard deviation on the less dense side, then you at least have osteopenia. So a T-score of -1 is one standard deviation away from the average for a 30-year-old woman. And if you have a T-score of less than 1, but greater than -2.5, you have osteopenia. And if you have a T-score of less than -2.5, which is 2.5 standard deviations away from that mean, then you, by definition, have osteoporosis. I would mention just, again, that there may be concern because the DEXA scanner does use X-rays, and there's always a concern about exposure to radiation. The amount of radiation that's delivered in a typical DEXA scan is less than what's delivered in getting a chest X-ray. It's a very, very low dose radiation procedure. I can't say that there's no risk to it long term, but it's really a minimal risk. So if you fall into the osteoporosis range at any one site, then you have osteoporosis by definition. So you can have a normal lumbar spine and you can have a normal total hip, but if the femoral neck is in the osteoporosis range, then you have osteoporosis, and the same is true for any of the other sites also. If your lowest bone density is osteopenia, so if you have osteopenia at one site but everything else is normal, then you have osteopenia also. Okay. You may find yourself at a health fair, and they may do a bone density scan of your ankle here. That's maybe okay as kind of a screening test type of thing, but it's not accepted as part of the definition of diagnosing osteoporosis or osteopenia. If there's any question about whether you may or may not have osteoporosis or osteopenia, you should get a formal bone density scan at a scanner that does the lumbar spine and the hip. So, okay. Who should be tested? The primary group that needs to be tested are women starting at around the age of 65. So most healthy women who don't have other risk factors for osteoporosis should start getting scanned at around age 65. If your bone density is borderline or if it's in the osteopenia range, then you should probably get retested again every 2 years to monitor whether there's progression of the disease or not. If you fall in the normal range, if you're well into the normal range, then probably you don't need another one for at least 5 years. Okay. Women who should get tested earlier than age 65 are women that have specific risk factors. And risk factors would be a family history, smoking, being on a high-risk medication. Those would be the main ones there. So.
What about like bone spurs, if you have bone spurs, or arthritis? Are those risks?
Bone spurs and arthritis are totally unrelated. Osteoarthritis is a totally unrelated disease to osteoporosis. Osteoarthritis is a disease of the joints, whereas osteoporosis is a disease of the bones. Mm-hmm.
Factor is a thin person too. Why is that?
Well, because most thin people have less peak bone mass. So I'm tall. I'm very tall and thin. The other risk factors are Northern European ancestry or Asian ancestry. But there's such a wide overlap between different ethnic groups that we recommend not making a distinction in terms of screening. So, there's still overlap between the lowest bone density for a African American male versus a Caucasian female. So there's just a wide variation between ethnic groups. So you can make generalizations about that, but we don't use those to guide recommendations for who should be screened and who should be tested. So. But yes, I'm tall and thin, and I have a Scandinavian last name, and there was a period of time where I was spending most of my time indoors, and I don't really like milk very much, and I have osteopenia, and when I did some testing, I found out I was deficient in vitamin D, so it can happen to anybody.
I wonder if it can affect all the bones in your whole skeleton.
That's a really interesting question because when we do bone density testing, we do see differences where in one area it may be normal and in another area it may show osteoporosis, but the assumption is that if you have it in one place, you have it everywhere. So the places that we worry about the most, of course, are the spine, the hip, and the forearm because that's where most of the fractures occur. Mm-hmm. So those are the people that should be tested, and the recommendations we recommend, again, starting usually at around age 65, especially for women, unless there's specific risk factors, in which case you should start getting tested earlier. So if you are diagnosed as having osteoporosis, what can you do about that? For people who have osteopenia, I usually just recommend taking calcium and vitamin D supplementation. And most people don't get enough calcium in their diet. I usually recommend taking 1 to 2 of the calcium citrates because the calcium citrate is a little more easily absorbed than the other types of calcium supplementation. So I recommend taking 500 to 1,000 milligrams of that a day. And then as far as vitamin D goes, nobody really knows the right answer to that question. And it's highly controversial. But it seems like you should take at least 800 units a day. Some people recommend higher amounts of vitamin D. There seem to be other benefits to vitamin D, including a better immune system, maybe decreased risk of some other diseases. There are people out there that recommend as high as 5,000 units a day of it. There are some concerns that excessive doses of vitamin D and calcium may increase your risk of vascular disease, like heart attacks and strokes and things. So I tend to be a little cautious with that. But I think you should take a minimum of 800 units a day, especially if you have osteopenia. So, okay.
You said 5,000 calcium?
No, 500 to 1,000. 500 to 1,000. And I usually recommend the calcium citrate because it's a little easier to absorb that. There was another question back here.
What's a normal level for vitamin D?
Well, you can measure vitamin D levels. Again, vitamin D levels are a little controversial as to how accurate they are. But we want to have, I usually look for a vitamin D level of at a minimum of 25. I've forgotten the units on that, but usually about at least 25, and I'm more comfortable if it's 35 or above. And I don't think you necessarily want to push it up to very high levels because I do believe that it is possible to get too much vitamin D and get vitamin D toxicity, and that there may be some long-term risks, even modestly too much vitamin D. So you have to kind of... So for osteopenia, I don't recommend anything more than that. I recommend going on calcium and vitamin D supplementation and then rescreening in 2 years, okay, to make sure it doesn't appear to be progressing. For people with osteoporosis, there are other options available. There are medications, and someone earlier asked a question about Fosamax or alendronate. The workhorses of treatment for osteoporosis, other than calcium and vitamin D, are now the bisphosphonates. And that includes alendronate, which the old trade name was Fosamax. And then there's I think it's ricidronate, but it's Actonel. And then there's Boniva. That's the one Sally Field advertises. And then there's an IV form called Reclast. And bisphosphonates have been shown to increase bone density and to reduce the risk of osteoporotic fractures over a long period of time. All medications have potential adverse effects. There's no such thing as any medication that is risk-free. Although the risk of bisphosphonates seems to be actually relatively low. The most common one, and the one you probably should be most aware of, is that if you have a bad problem with acid reflux or any problems with any type of a stricture in your esophagus, then you maybe should be cautious about taking them, because if those pills get stuck in your esophagus, or if the medication gets refluxed back up into your esophagus, it burns really bad. You can get a very severe esophagitis from it. And there have been isolated cases where it's even burned a hole in the esophagus, and that's a really, really bad thing to happen. So, but most people tolerate it really well. I prescribe the medication to a lot of my patients, and the vast majority tolerate it quite well. But I do always ask them about if they have a problem with reflux before or problem with having trouble swallowing and having food get stuck in their chest on the way down before I prescribe a medication like that. The alternative to taking it orally is to take the Reclast, which is an IV infusion, and you only need to do that once a year. So, and that, of course, bypasses the esophagus because we give it intravenously. Some of the other side effects that you may have heard about with bisphosphonates include the one that was mentioned, which is necrosis of the jaw. Again, there's some differences of opinion as to how often that occurs. We believe that it occurs very seldomly. It's actually quite a rare occurrence. I believe some dentists dispute that based on their, I don't think there's any studies to prove it one way or another, but they just think that they see a lot of those kind of cases in their offices. But in terms of actual studies go, it's a very rare occurrence. Now, necrosis means basically dead dead cells. So if you have osteonecrosis of the jaw, that means that the bone in your jaw died, and that's clearly not a good thing to have. So it is a serious complication. It's one to be aware of, but it's one that occurs quite rarely. I've never had a patient that I'm aware of that had it, and I've prescribed the medication frequently. So it requires a population of people that's larger than the population in my practice before you're likely to see one person that had it. So another one that you should be aware of, and this is a real one, again, it's pretty rare, but it certainly can occur, is atypical fractures. And that's for people that have been on a bisphosphonate, particularly alendronate, for longer than 5 years. If you're on the medication for longer than 5 years, you can develop fractures in the middle of the femur. Now, most osteoporotic fractures occur up in the hip, in the femoral neck. These fractures, atypical fractures, occur in the mid shaft of the femur. And they're very bad fractures. You don't want to get an atypical fracture. So again, it's very controversial as to how you prevent that or what you do about that, but some physicians recommend taking a 1 year or 2 year holiday from the bisphosphonate after being on it for 5 years. And then it seems like it's safe to maybe go back on it again after 1 to 2 years. The downside of that is that there are studies that show that as soon as you stop taking the bisphosphonate, your risk of fractures, of typical fractures, starts going up. And of course, the incidence or the likelihood of getting a typical fracture is far greater than the likelihood of getting an atypical fracture. Other options, there's some newer options. There's a medication called Forteo that's an injectable medication that you take once a day for 1 to 2 years. It can build bone very rapidly. The bone that's built by Forteo is not normal bone. It's more of a cake-like bone. But it is stronger, and it reduces the risk of fractures, and it does seem to help. And there don't seem to be any other major severe side effects. There is a black box warning that in animals, in like laboratory mice and rats, that it caused bone cancers. They have never been reported in people, to my knowledge. So. And then there's a brand new medication out that you may have heard of called Prolia. Prolia is one of the biological agents that I'm not even sure how it acts in terms of treating osteoporosis. Biological agents in general bind to lymphocytes or to immune receptors on cells and things like that. So they're often used to treat inflammatory conditions like rheumatoid arthritis and lupus, and they're used to treat hematologic malignancies like lymphoma or lymphocytic leukemia. So I'm not quite sure how Prolia actually works to increase bone density. There is some downsides to it, though, in that it does impact your immune system over a long period of time. So, but it pretty much shuts down bone resorption. And anything that shuts down bone resorption still has the risk of the jaw necrosis and the atypical fractures, too. So, okay. Okay, we'll talk a little bit about Evista. That's a really good question because we kind of skipped over estrogen and hormone replacement therapy. For a long time, the best defense against osteoporosis for women was to take hormone replacement therapy. The problem is that over time, we've now come to learn that there are risks to doing that, such as increased risk of breast cancer, increased risk of uterine cancer if you haven't had a hysterectomy. There are probably also increased risks of cardiovascular events such as strokes and heart attacks. So we've pretty much stopped recommending hormone replacement therapy, that was our main defense against osteoporosis for a long time. Evista is it's a type of estrogen that is specific apparently for bone receptors, or more specific. And there is some evidence that it may actually be preventative for some types of breast cancer also. It can increase, it increases the incidence of hot flushes. It may increase the risk of thromboembolic disease, so blood clots in the legs and things like that. I don't find that Evista is really widely used by a lot of physicians right now because of some of those concerns, but it is an option for probably more for prevention than for treatment at this point. So.
If you start taking the medication, how long will it take to notice it's working?
That's a really good question also. The soonest that it's recommended in general to retest bone density to see whether it's actually increasing bone density is 2 years. And there's 2 ways of measuring success in treatment. There's something called a relative risk, which means that you compare 2 groups of people and you compare the treated group and the untreated group. And if one group has more of something than the other one, then you calculate the difference and get something called a p-value. And sometimes that can be a little bit deceiving as to how effective something actually is. Another way of looking at success in treatment is something called number needed to treat, and then there's also something called time horizon, which is how long you need to treat them in order to see the benefit. And with all of these medications, with bisphosphonate, at least with bisphosphonates, in terms of time needed to treat and time horizon, you need to treat anywhere from, depending on what study you read, you need to treat anywhere from 40 to 120 people for 3 years. So that means, that doesn't make you as enthusiastic about taking the medication as knowing that there's a significant p-value there, does it? Or that there's a relative risk of 2 or 3 or something like that. So that's a little bit of a sobering number and makes you stop and think twice before you want to take a medication that there's only a 1 in 40 or 1 in 20, 1 in 120 chance that it's going to actually benefit you. So.
I have a question about the gummies.
The gummy bears?
Yes, because my doctor told me he takes
Yeah, they're fine.
for calcium.
Yeah.
But I couldn't find out when I did how strong it was. They would call them, but they just didn't.
Somewhere on the label there, if you in the fine print, you'll find a number of milligrams of how many milligrams of calcium there are in that. And I don't know the answer myself, but
Because in the pharmacy they told me you need to take 4 a day, but don't take them at the same time.
okay,
It goes in your system.
okay.
But do you think that is true? It goes in your system?
It does.
Well,
I think so. I don't know if it's any faster, but it's just as good anyway. So any way you can get the calcium, a lot of my patients don't like, calcium pills are big and and a lot of my patients just tell me they can't swallow them. So whatever way you can get them is fine. There's candy that you can get that has that's a calcium supplement. They're like little wafers of like chocolate and caramel and things like that. And then there's the gummy bears. A lot of they're starting to fortify, some companies fortify things like grapefruit juice and orange juice and things like that. And there may be fortified cereals and stuff like that that have some calcium in it too. Any way you can get the calcium is great. So.
Doctor, at what age should a man get an initial bone density test if there are no risk factors?
Well, that's a really good question too. My answer would be probably at around age 75 because usually men lag behind by about 10 years, and we usually recommend that most women get started testing at about age 65. Unfortunately, the insurance companies don't really see men as being at risk, and so they don't want to pay for it as simply a screening test. So in terms of insurance paying for the test, you need to have some kind of a risk factor. So, if you have an alert doctor who notices that you've lost, that a man has lost an inch or an inch and a half in height, that may be a reason. Or if they're on any of the high-risk medications, or are smokers, or in my case, very tall and very thin and have a Scandinavian last name, that might be a reason to start testing. So, any other questions? While I'm waiting for some other questions, I don't want to forget about this, and I'm just going to pass these things around. The thicker of these two is a normal vertebrae. It's a representation of a normal vertebrae, and the other one is an osteoporotic vertebrae. And one thing I want to emphasize, it's not just simply a loss of volume of calcium. You actually lose the struts, for lack of a better word, or the bridges, the bridging, so that the structure actually becomes weaker just because of the loss of the lattice work there. So I'm going to go ahead and pass these around. Just take a look at them and then go ahead and pass them around while we're finishing up talking here. So.
I've been reading about, I think I'm having trouble absorbing calcium and vitamin D, and then nutrients or other minerals that can be combined with it, maybe magnesium.
Yeah, those are kind of areas of what I would characterize as unproven efficacy. If there's a problem with absorbing calcium, I think taking vitamin D with it is your best bet. There are some ways of measuring bone turnover. You can measure a 24-hour urine calcium to see how much calcium your body's putting out, and then you can also there's a test called telopeptide that we sometimes use. That's a measure of bone turnover also. And you're wanting a lower, if you're treating osteoporosis, your goal is a lower bone turnover rate. So.
Are there any chronic diseases that would lead us more towards getting osteoporosis? Like in our family, there's a couple of us that have celiac disease.
Malabsorption diseases of the GI tract would be a risk factor. There's a condition called hyperparathyroidism that's actually more common than a lot of people think, where there's too much parathyroid hormone and that increases bone turnover. So yes, there are some chronic diseases that do that. At an earlier age, absolutely, yes. Mm-hmm. Well, you can. I've had people get compression fractures just from stepping off a curb too hard. But one question that I thought I might get is what comes first, the fracture or the fall? Because that's a common question. But that actually has been studied, and we believe that most hip fractures are actually caused by the impact of the fall. It's a little bit of a myth that the fracture comes first. So, okay.
That would be for that other stressor also people
That I don't know. I don't know how those fractures occur. They're quite rare, but they do occur. There also there's a precursor to the atypical fractures, and that is you get pain in the middle of your upper leg. So if you're taking osteoporosis meds and you develop a persistent pain in your upper leg, you can actually get an X-ray of that, and you can see there are some X-ray changes that you can see before the fracture occurs that alert you that it may be a thing. So that's something to be aware of if you're taking osteoporosis meds. Mm-hmm.
Also, take the alongenate now. Is that actually rebuilding the bone, or is it just keeping the osteoporosis?
We think it does rebuild bone, probably not completely, and it does it very slowly, but we do think that it increases bone density and reduces, actually bends the curve on the fracture risk. So. Mm-hmm. Okay, I think, again, if anybody wants to see the differences in the bone structure, you can kind of come up and take a look at it. And thank you for your questions, and thanks for attending.